Hello again. This is now your recording for chapter 35, heart failure. This is still a perfusion. Now, heart failure is never a primary condition, as defined here. It's also called pump failure. It is a general term for the inability of the heart to work effectively as a pump. Many conditions cause heart failure. Like I said, it's never a primary condition. Something happened that led to heart failure. It is therefore a condition, not a disease in itself. So it can cause from or result from a number of acute and chronic cardiovascular problems. Some of them may not be cardiovascular in nature. It can result from respiratory or some other mechanical cause. Although there are three major types of heart failure, we will only be discussing left side and right side. To explain left side and right side heart failure, let us do so using this diagram again here. We will explain how the symptoms occur based on the natural physiology of the blood flow of the heart. Blood flow through the heart. Before we proceed with that, let us look at heart failure classification according to the American Heart Association. Now, you may see this question on the NCLEX, not based on these ABCD classifications, but rather what are the patients allowed or not allowed to do depending on their heart failure classification. For instance, when a patient has class 1 heart failure, that means they only have a high risk of developing heart failure. They do not have heart failure necessarily. Now, the other classification are also under class 1, maybe patients with cardiac structural abnormalities or remodeling, but have not developed heart failure symptoms yet, meaning these structural abnormalities may be affecting the valve or may have resulted from, let's say, a compensated event. For instance, let's say the patient has a minor a heart attack, not a full-blown heart attack, but let's say the patient has angina, for instance, which occasionally will cause ischemia. However, that patient does not have heart failure not have heart failure symptoms yet, so they fall under class 1. Class 2 or 3 are now patients with current or prior symptoms of heart failure. And then finally, class 4 are patients with refractory end-stage heart failure, meaning these are people who require a heart transplant already. Now, how may this section be tested on the NCLEX? This may apply to a pediatric, psychiatric, med-surg, or even maternity patient. So, for instance, if you're the scenario says the patient is 6 months pregnant and has class 2 heart failure, will that patient be allowed to go into labor, for instance, or will the patient now require C-section? Okay, so that's just an example. You will look at the signs and symptoms later as we progress through this chapter, but bear in mind the classification, okay, and then the patient's limitations as a result. Let us review compensatory mechanisms, because these will affect significantly the patient's ability to compensate, and will also be the basis of your not only signs and symptoms, but also the treatment that you are required to give. Now, you may remember this in chapter 11, wherein you have natural compensatory mechanisms. The triggers, I believe, were low blood pressure, low blood volume, low oxygen, and low sodium levels. Now, when a patient is in heart failure, so from various causes, so let's use a heart attack as an example. If a patient suffers a heart attack, will there be low blood pressure? Yes. Will there be low cardiac output? Yes. If in case you're wondering, there will be low cardiac output and low blood pressure because the heart itself, in a heart attack, a section or sections of the myocardium are dead or are severely deprived of oxygen because of either a blood clot obstructing blood flow, or I should say usually a thrombus obstructing blood flow, which will result in acute ischemia, and unless relieved, then the myocardium will die. As a result, its pumping ability, it will be greatly reduced, hence the low blood pressure, and of course that will result in low oxygen delivery resulting from low perfusion. So the three compensatory mechanisms described here are the following. We have the sympathetic nervous system stimulation, the renin-angiotensin, aldosterone system. Other chemical responses are of course mentioned in chapter 11 are the ADH secretion as well as the BNP. BNP is brain type natriuretic peptide, which is cardiac specific, as we discussed in chapter 11. But let's review. So imagine that the patient had a heart attack, has ischemic heart disease or coronary artery disease, angina, unstable angina falls under that, hypertension, or any other causes. There will be a table listing the various causes and risk factors for heart failure shortly. Now again, let's use MI as an example. So there is low cardiac output in MI, therefore resulting in low oxygen delivery. So here we go. There is reduced cardiac output, the reduced systemic blood pressure as a result, and that will trigger these baroreceptors, finally leading to your adrenal glands to respond. These will result in the release of epinephrine and norepinephrine, which has two effects. It will now increase vasoconstriction, increase heart rate, in an effort to increase blood pressure. Now imagine, in the first place, this patient suffered a heart attack, which resulted in low oxygen delivery throughout the body. Not just throughout the body, but including the myocardium itself, since the heart has to supply itself with oxygen during diastole. Now, if the body responds this way, by increasing afterload in an effort to increase blood pressure, now imagine increasing the heart rate and increasing afterload, which increases the workload of the ventricles. There is no oxygen in the first place. So does this make sense as a efficient way to respond, wherein you respond to low blood pressure and low cardiac output, low oxygen levels, by increasing oxygen demand and increasing workload, which again increases oxygen consumption? Now this can be devastating, therefore, because there is simply not enough oxygen to go around. That's what triggered this event in the first place. So do we want to have this response, this sympathetic nervous system stimulation, to continue? The answer is no. Hence, one of the treatments for heart failure is a beta blocker, or more specifically, there is beta adrenergic blockers. We need to stop this event because this is not a very efficient way to respond to low cardiac output and low blood pressure. The second response is the RAS system. So that's renin-angiotensin aldosterone system. This again responded because once the kidneys sensed the low cardiac output, which resulted in low kidney perfusion. Remember, in sympathetic nervous system stimulation, the purpose of this vasoconstriction is to shunt blood. The blood will only be shunted to the three most vital organs, namely the heart, the brain, and the lungs. Kidneys are not, although personally it's a vital organ, but since it's in the periphery, blood flow to the kidneys will be reduced. So here is our trigger. Therefore, that will trigger the release of renin-angiotensin, trigger renin-angiotensin aldosterone system in the adrenal glands. So first part is renin-angiotensin, which leads again to vasoconstriction, again increasing preload and increasing workload, increasing oxygen demand. On the other hand, on the aldosterone side, that will increase water reabsorption as well as sodium retention, increasing blood volume, which is preload. Now take note that this patient is already in heart failure. They cannot handle increased blood volume or increased preload. So to stop this event as well, we need to give what drug? If you answered ACE inhibitors, that is correct. So we give ACE inhibitors to stop this whole event from continuing. So we will inhibit renin-angiotensin converting enzyme. We will inhibit that. Therefore, this event will cease to continue. And if you remember BNP, we will discuss BNP next. Okay, I hope you understand preload and afterload at this point. Let's go to BNP. As we did in chapter 11, BNP is produced and released by the ventricles when the patient is in fluid overload from heart failure. Meaning this is now triggered by the stretching. Remember the stretching? Now, when did the heart become stretched? So let's use the same example. Patient had a heart attack, either left side or right side heart attack. That led to decreased myocardial contraction because of course the myocardial cells died, so therefore that will decrease the heart rate and decrease the contractility of the heart. So therefore there will be blood pooling in the ventricles as a result. That will increase preload, and preload as a result will result in increased stretching of the ventricles in order to accommodate the increased preload or increased blood volume. That will trigger the release of BNP produced by the ventricles themselves. Now there are two results here. The BNP will trigger diuresis in the kidney, right here, diuresis, as well as vasodilation. So therefore, two effects here. These hormones will decrease preload by promoting vasodilation and will decrease decrease afterload by causing vasodilation, and then decreasing preload by promoting diuresis. So it will both decrease systemic vascular resistance as well as blood volume. Okay. Now BNP is only cardiac specific. No other cell in the body produces BNP. So rise in BNP levels can only mean one thing. It is caused by the patient being in heart failure. The reason is we need to be doctors need to rule out the cause in the soonest possible time, because these patients present with the same symptoms when they enter the emergency room, regardless if it's a pulmonary or cardiovascular cause. Patients present with shortness of breath. Now we only have a few minutes in order to make a diagnosis and then treat these patients as soon as possible. So one of the first blood tests that the doctor will order, among others, will be a BNP level. So that would be kind of a shortcut. So if a patient has elevated BNP, then that narrows our that will narrow our suspicion to heart failure and will rule out other causes. Let's now talk about the common causes and risk factors for heart failure. Table 35-1. Hypertension. Hypertension increases afterload. So at this point I will only be using preload and afterload, so I really hope you understand the concepts. So hypertension increases afterload. Coronary artery disease also causes increased afterload because the coronary arteries again perfuse during diastole. So if the patient's cardiac output is low, then that means coronary artery perfusion is also low. Cardiomyopathy, which is discussed at the end of chapter 35, is a either congenital or a acquired disease of the heart. There are I think there are two major types of cardiomyopathy. There's a dilated and a restrictive cardiomyopathy. Anyway, we'll discuss this toward the end of the chapter. Substance abuse, alcohol increases preload. They cause vasoconstriction. Illicit drug use, mostly these drugs are stimulants, so they do increase afterload as well as also increase heart rate, which increases oxygen demand. Valvular disease, this as previously described in the previous video, valves affect afterload if they either don't open completely or do not close completely. Congenital defects are more common in pediatrics, so I will leave that for pediatrics. Most common congenital defects are there is a hole that did not close in utero between the right side and the left side of the heart, or where the interventricular septum is supposed to be. So that will lead to shunting of blood from the right or left side of the heart. But anyway, this will be discussed in more detail under pediatric, under cardiovascular conditions. Cardiac infections and inflammations, we will discuss this in chapter 35. This is referring to endocarditis and pericarditis. Dysrhythmias, as I already mentioned in the previous video, this will affect the unidirectional blood flow through the heart. Diabetes mellitus causes vascular problems, which will increase afterload. Smoking or tobacco abuse, of course, causes vasoconstriction, which increases afterload. Family history, usually hypertension, high cholesterol, which all increase afterload. Obesity, of course, leads to hyperlipidemia, which causes narrowing of your arteries. That will again affect afterload. Sleep apnea, or as well as severe lung disease, as previously mentioned in the first video. These cause pulmonary hypertension, which increases afterload on the right side of the heart. And non-cardiac causes include hyperkinetic conditions such as hyperthyroidism, which increases heart rate, therefore increases oxygen demand and cardiac workload. Now let's go to signs and symptoms. I encourage you to read the whole paragraph, both left side heart failure as well as right side heart failure, but I would like to take a shortcut and discuss it using the two charts, charts 35-1 and 35-2. Now let's review again the blood flow through the heart. Okay, I hope everybody has this down pat. So let's begin with left side heart failure. Left side is this side right here fails. It's usually the left ventricular failure. So this left ventricle failed as a result of the various causes we just listed or just discussed in table 35-1. So let's begin with your signs and symptoms. So remember, the left side or the left ventricle is responsible for pumping blood through the systemic circulation, through the aorta. So it only makes sense that your signs and symptoms reflect that. It is also responsible for receiving blood from the lungs through the pulmonary veins. So therefore, failure of the left ventricle will result in blood pooling inside it and a backward flow of blood to the left atrium and then eventually into the right and left lung, which results in pulmonary congestion. So here we go. Therefore, there are two columns here for chart 35-1. They will because again the left ventricle is responsible for pumping blood through the aorta. That will therefore lead to decreased cardiac output. And because it's also responsible for receiving blood, oxygenated blood from the lung, and in heart failure will result in backflow of blood from the left ventricle to the left atrium and then eventually into the lungs. Then therefore the patient will also manifest pulmonary congestion signs and symptoms. So let's explain each one. Under decreased cardiac output, because blood is not going through the circulation now. So imagine here, blood is supposed to leave the left ventricle and enter the aorta. First, two branches of the aorta are the left and right carotid arteries, which supplies blood and oxygen to the brain, hence therefore, and then the rest of the body. So it only makes sense that the patient will present with fatigue and weakness because all cells of the body will be deprived of oxygen. There will be oliguria because like I mentioned already, during shunting because this will trigger sympathetic nervous system response, there will be decreased kidney perfusion. As a result, because there's less blood flow to the kidneys, then the kidneys will also make little urine. There will be oliguria, which is less than 400 ml urine output per day, while there is increased urine production at night. Now the reason for this is the metabolic demands are naturally higher during the day because you're more active, and as the metabolic rate decreases during the night, everything slows down, oxygen demand decreases systemically. Now finally the kidneys now receive blood flow, so they make up for all that oliguria during the day, and then there will be a resulting nocturia at night, which again contributes to more fatigue and weakness because now the patient has to get up a few times at night in order to pee. There will be angina because remember the heart muscle itself receives blood from itself. The coronary arteries receives blood during diastole or during heart relaxation. So if there is decreased cardiac output, naturally there will also be less blood flow to the coronary arteries. Confusion and restlessness, that's a given because again the first two branches of the aorta are the carotid arteries, so if there is less cardiac output, then there will be less oxygen to the brain, leading to confusion and restlessness as well as dizziness. Tachycardia and palpitations are a direct result of your sympathetic nervous system response, which increases heart rate. There will be pallor, again because of vasoconstriction, again resulting from sympathetic nervous system response. And because there is decreased cardiac output all over, especially in the peripheries, there will be weak peripheral pulses and cool extremities at the same time. Now on the pulmonary congestion, because blood will leak water via hydrostatic pressure in the lungs, because there is now congestion in the pulmonary veins. Water will eventually leak out, causing vascular damage, and then now water will enter the alveoli, leading to pulmonary edema. All these 6 symptoms listed here under pulmonary congestion are all symptoms of pulmonary edema. So the crackles, the hacking cough, the dyspnea, and the pink tinge frothy sputum, increased respiratory rate are all signs of pulmonary edema. Now let's go to chart 35-2. So that is the right side now. So if the left side is responsible for systemic circulation as well as emptying blood from the lung, the right side is in charge for receiving blood from the upper part of the body via the superior vena cava, as well as receiving blood from the inferior vena cava, which comes from the lower half of the body. Now let's use the same cause. Let's say this patient suffered a massive heart attack involving the right coronary artery, leading to death of the myocardium on the right side, on the right ventricle. Now this pump, therefore this side of the pump of the heart will not beat effectively, so blood that is supposed to enter here cannot leave. It will distend the right side. There will be increased preload here, and eventually there's only one place it can go. So if there's congestion in the left ventricle, there will eventually be congestion in the right atrium, and all the blood that is supposed to enter there will have to wait. Everything will be backed up to wherever they came from. So from the upper part of the body, that will be manifested as the following. So there will be jugular vein distension, because blood from the brain cannot drain, resulting in the distension. Blood coming from the lower part of the body has to pass through the portal circulation or through the liver, but since they're congested there too, that will result in an enlarged liver and spleen, along with other GI symptoms like anorexia and nausea, because this will now irritate your vagus nerve. Dependent edema will occur. Now take note that dependent edema does not occur early. This thing does not show up until a significant amount of fluid has been retained, meaning usually about 4 to 7 liters of fluid must be retained before it forms edema. This means once there is dependent edema, this is already a late sign. Okay? This is already full-blown heart failure before these things occur or are evident. There will be distended abdomen because the blood congestion in the liver has to go somewhere. Now blood will not leak out of a blood vessel, only water. So on top of dependent edema, this will occur in any dependent area, the legs, the arms, sacrum, even the scrotum, any dependent area depending on the patient's position. Now, which is most likely going to be in a recliner. Patient will probably be in a high Fowler's position, so that will leave your sacrum, your scrotum, the legs, and even the arms as dependent areas. So that will be all the areas that will form edema, and that will not spare the abdomen. So some fluid from the liver, from water, will also leak into your peritoneum, resulting in abdominal distension. As I already mentioned, there will be swollen hands and fingers. Now, the same as in left side, when metabolic demands decrease at night, then there will be increased urine output during the night. The weight gain here is simply because the kidneys are not making urine. Now, imagine the kidneys will normally produce about 1500 ml of urine per day. If they do not make urine, then that means all that water is that's supposed to come out as urine is now retained in the body in the form of fluid. So that's where your weight gain comes from. Now the last bullet here, wherein there is increased blood pressure or decreased blood pressure, can be a bit confusing, but let me try to explain this. When a patient has heart failure, now heart failure is chronic. However, there can be acute episodes wherein the symptoms occur within a short time, making interventions necessary. Now, these patients also live with chronic heart failure, meaning day to day they may have mild symptoms of these. They will present with these features every day at minimum levels. So day to day, when they are not in acute decompensated heart failure, there will be increased blood pressure because there is increased blood volume. However, because they are still compensating, the blood pressure will still be high, meaning the patient is still able to compensate. I'm referring to the sympathetic nervous system response as well as the renin-angiotensin-aldosterone system. Now, when these patients start to decompensate and will have acute exacerbation of heart failure, meaning they are now completely decompensated, then cardiac output will drop, okay, because they will have symptoms of acute heart failure. We will discuss treatment, laboratory assessment as well as treatment in a separate video.